further ado, I'd like to introduce Dr. Carla Boutin-Foster. Dr. Boutin-Foster is the Associate Professor of Medicine and Associate Professor of Healthcare Policy and Research at Weill Cornell Medical Center. She's also the Director of the Center of Excellence for Health Disparities Research and is incredibly dedicated to tackling health disparities and overcoming the limited health and resources that communities have. I met Dr. Boutin-Foster about 6 years ago, and I've stayed close to her since because she is an incredible person. She is completely dedicated to the work that she does, and in my opinion, she has the Midas touch. So, Dr. Boutin-Foster, please come. Thank you.
I'm going to help her. She's not going to turn to gold, so you know I don't have money. Thank you so much for inviting me, and I'm really humbled to be here with all of you guys who really do the work. So I thank Jennifer Melendez for inviting me and introducing me actually to Takeesha White, who invited me. I think Dr. Smith, who I met maybe 2 or 3 years ago, and he told me what he was interested in, and it's just been a wonderful relationship ever since. So what I'm going to talk about is really give you an overview of some of the disparities that exist in the communities, which I'm sure you're all aware of, and then hopefully give you some ideas as to what I think where some of the solutions lie. I'm just seeing some of the my friends in the audience there. Hello. So what are health disparities, right? When we talk about health disparities, according to the NIH, health disparities are differences in the incidence, prevalence, mortality, and burden of diseases and other adverse health conditions that exist within specific groups in the United States. And differences between groups tend to be those between racial and ethnic minorities and non-racial ethnic minorities, as well as differences that exist across income strata, so those who are less privileged or have fewer social resources than those who do. You know, these disparities are systematic, they're not random, but yet they are amenable to change. So when we talk about disparities, disparities exist. If you think of any of the conditions that Dr. Smith mentioned, disparities exist in this field, right? So how many people know someone with cardiovascular disease, right? Okay. So coronary heart disease, the impacts racial and ethnic minorities more so than Caucasian adults. In particular, African Americans have the highest risk of hypertension, and not only high blood pressure, but uncontrolled blood pressure. So it's one thing to have a chronic condition, and then there's another challenge in getting people to manage this condition so that the adverse impact of hypertension and diabetes do not occur, and they do not occur at a younger age where people are in their prime. So what Dr. Smith is talking about when he talks about dialysis, this is something that we could in large measure prevent if we control the disparities in hypertension. We talk about diabetes, another contributing factor to end-stage renal disease. How many people know someone with diabetes? I should make you guys get up and sit down, but again, racial and exercise, right? Racial and ethnic minorities are also disproportionately impacted by diabetes and its complications. I mean, from head to toe, we know what diabetes does, whether it's the brain, a stroke, or the eyes, or the heart, or the limbs, or fatty liver disease, or even, we don't even think about diabetes when we look at the rates of premature births, and even infertility, right? So we have to look at these conditions or things that are preventable because in and of themselves they cause problems, but also the complications that are attributable to hypertension and diabetes, right? So when we talk about diabetes, we also tend to focus on African American and Hispanic Americans who are almost twice as likely to have diabetes. But we often forget that a growing number of the South Asian population, up to 4 times more likely to have diabetes. So we need to really look beyond disparities as something being black or white, because it really impacts communities in which I live and you live. Native Americans, Alaskan Natives, almost 3 times as likely to develop diabetes. Hepatitis C. Hepatitis C, there's been an increased interest in hepatitis C, especially with our baby boomers, so that the Department of Health has asked that physicians at least screen their patients for hep C. When it comes to hepatitis, we know that racial and ethnic minorities have a higher prevalence, but there's also a difference in their ability to respond to the treatment. Now, it may be genetic, that may be one thing, but it may also be a larger body mass index, in insulin resistance, or the fatty liver disease that I talked about with diabetes, right? So these are other disparities that we often don't talk about. Cancer. We've observed a decline in the rate of cancer, yet it is less so in racial and ethnic minorities. We know that black men have the highest rate of prostate cancer worldwide. How many people know someone with prostate cancer who has had prostate cancer, right? What about colorectal cancer? We know that in racial and ethnic minorities, colorectal cancer starts at an earlier age, right? And yet, we don't talk about colorectal cancer as a disparity. Breast cancer. How many people know someone with breast cancer? Right? The incidence of breast cancer remains highest among white women, yet it's the racial and ethnic minority women who are dying at a faster rate with breast cancer, presenting later with breast cancer, and with more aggressive, what's been known as triple-negative breast cancer. So another disparity is asthma. Who doesn't know someone with asthma? Just see if you guys are paying attention, right? So some of you work in communities where there are the highest rates of asthma. You know, and it's not only the asthma, it's the impact that asthma has on one's ability to work, the missed days of school, and ability to play, the frequent emergency room departments, and the mortality. So we have a lot of work to do. So just to summarize thus far, it's well established, tons of data about the racial and ethnic disparities when it comes to health disparities and conditions such as cardiovascular disease, asthma, diabetes, HIV, and AIDS. And we know that racial and ethnic communities and minorities in these communities, people living in these communities, have poorer outcomes. We also know that this is not by accident, that there are social determinants of health that underlie and sustain these disparities. You know, there are factors that continue to fuel the disparities so that they exist. And this is what you guys are here to address. Each year, however, the NIH spends close to $3 billion in addressing health disparities through different work. And the NIH has done, made tremendous strides, has done some great work. But $3 billion on something that's largely preventable, right? $3 billion. We've gone from Healthy People 2010 to Healthy People 2020. So we're going towards Healthy People 2030, and are we going to be still singing the same song? Right? So if we want to sing a different song or to write something different about what we did in 2020 that we don't have to repeat in 2030, we have to move from community outreach to transformation. We need to focus on the unequal distribution of resources. So now I'm going to transition to health equities. We should transition from health disparities to promoting health equity. Health equity is the promotion of equal opportunities for all people to be healthy and to seek the highest level of health possible. And we know that our health is so important to us that without our health, a lot of us wouldn't be able to do what we do. So health is such an important aspect of our lives. And I don't know about you, but it ought to make you angry. You remember the old song, It Makes Me Want to Holler, right? It should make you angry that there are systematic problems that exist in communities, largely communities of color, racial, ethnic, minority communities. It ought to make you angry. So we need to make sure that the equal distribution of social and economic resources needed for individuals to be healthy so that we can then work together to reduce disparities and improve health for all. So, the social determinants of health. Now, some will consider race, ethnicity, and gender as social determinants, and in some cases, they're proxies for some of these factors. You know, these are determinants that individuals of certain race, ethnicity, and or gender may be more susceptible or have less opportunities for employment. You know, we often take it for granted. We complain about going to work, but imagine if we didn't have that, or we didn't have an option, and not only did you have to take care of yourselves, but your children, maybe even your nieces and nephews, right? So employment. Exposure to stress, right? So uneven distribution of the opportunities for stress, unevenly distributed in racial and ethnic minorities. Without the social support to counteract that stress, that ought to make you angry, right? Social exclusion, whether it's through being in schools that do not allow opportunities to network, or living in communities where you're socially isolated from health opportunities to eat healthy meals or participate in physical activity. So I was speaking with these two residents who just did a home visit, and they went to visit a woman who lives uptown, and they were telling me that this woman had not been coming to all of her visits. She had hypertension, diabetes, osteoarthritis, but she was not adherent, I'm sure you've heard that, right, to her medical visits. So they selected this person as someone to follow up, to go to their visits, to go visit her. And, you know, one of the residents was telling me that there was a lock, there wasn't a security guard, but there was a lock to go, you had to press in to be buzzed in to one sort of like archway, and then there was another buzzer you pressed to get further. So there were about 3 or 4 buzzers just to get through the door. You know, so I said, what did the lobby look like? You know, did you have a doorman? You know, did they offer you Avion water as you walked in? Were there flower pots? And they're like, no. They said, Dr. Boutin-Foster, it looked like Fort Knox. Okay? And then they had to walk up the stairs. So imagine this older adult woman who lives alone, who has bad osteoarthritis, who has a walker, which she had to go through to come to the doctor. And if she missed her assessor ride, she had to figure out how did she catch the train all the way to see the physician. So seeing this person, being in her living room, made it personal for them. You know, they realized that, wow, this woman is a falls risk, right? So it was important to be personal for them. You should have told me I had a minute 10 minutes ago. Okay, so let me move quickly. The next thing we need to do besides making it personal is we need to look beyond race. As I said before, race is not necessarily a biological construct, but a proxy for a lot of the social political challenges that people face. So we need to stop looking at it as black and white, because by and large, you can't change someone's race, right? So we can use race to identify who are those who are at highest risk, but then we need to move on and say why. Because when you focus on race and you stay on race, you end up blaming people, right? So we need to move beyond race. The other thing we need to do is to move where people move out of the clinics, the hospitals, and go to where people live, work, and pray. We have been able to do a lot of work through faith-based communities. Right, Stefan? Yeah, right? So we need to go to where people live, work, and pray. We need a diverse workforce. We people who are able to speak the same language, who have personal experiences, to come back to the academic center and say, hey, this woman reminds me of my grandmother. I know what she's going through. You know, this young man right here, that's my older brother. We need a diverse healthcare workforce in nursing, social work, pharmacy, public health. So we also need to view health disparities as a marker of social injustice that should not be tolerated in our institutions, in our communities, and we need to look at policies that inadvertently perpetuate disparities rather than bring a solution. So as you consider your planning programs, think of ways in which it can become personal to you. Because when something becomes personal to you, you will do it when you don't have the funding. And I unfortunately know that too well, right? So when it's personal, you'll do it no matter what. We have to become advocates for the people who live in our communities. We have to go beyond just giving out flyers at health fairs to following people up, to follow up. We have to tell our funders that we will no longer do health promotion without a purpose. What's the point in going to a health promotion event, giving out 1,000 flyers, not changing one life, right? So we need to get angry when our funders tell us, well, where are the numbers? Who have you reached? So I'm going to stop right here. Thank you so much for giving me this opportunity to share some of my experiences and some of the, I think some of the strategies that can be combined with your collective resources and expertise in truly transforming our communities. Thank you.